A very good afternoon to all of you. Frustrated by seeing the same patients come back to me again and again with the same diseases, and frustrated that much of the medicine I was prescribing was not going to the core problems that they were suffering from, I decided to follow them back to where they stayed. And for the last 10 years, I have been working with different communities in rural India. And what I will be presenting to you all today is some of the work that has evolved over the last 4 years, where I have worked with communities looking at health service accountability to the communities that they serve. About 2 years ago, in the district of Perambalur, in a village, a group of people sat around discussing what services were supposed to be available at the local Anganwadi center, which is the creche for under 6 children that the government has set up in every hamlet. There was a volunteer who had a checklist of services that were supposed to be there, and he was reading out from that checklist, and the parents who were sending their children to that local Anganwadi were telling each other whether those services were there or not. One of the questions was, are there toys and posters in the Anganwadi? The answer was no. The volunteer asked those parents, do you know why there are supposed to be toys in the Anganwadi? And the parents said, time pass. The volunteer said, no. Every time a child plays with a block or places one block over the other or rolls the ball to a friend, this is actually contributing to mental and physical development. The moment the parents heard that, they got quite agitated and immediately demanded from the Anganwadi worker, where are the toys? The Anganwadi worker said, there are no funds. The parents didn't take no for an answer. They went and discussed this issue with the Panchayat president and explained to him why toys were so important to be there in the local creche. And immediately, the Panchayat president allocated money from the Panchayat funds to buy toys for that local Anganwadi center. Today, if you go to that center, you will find that there are some wonderful local toys there and a bunch of ebullient and bubbly children. In Vellore district, in another village, another group of people were sitting around where a volunteer was holding a checklist of services that were supposed to be available to the general community. One of the questions was about the mobile medical unit. No one had heard about it. The volunteer explained that the government had introduced this program because it recognized that there were many hamlets that did not have direct access to the local primary health center, and thus a van with a doctor and basic equipment would go around to these cut-off hamlets twice a month. Now, for some reason, this particular hamlet, which people required 3 buses to go to the local primary health center, was left out of the map while there was planning going on. The people, having realized the logic of the mobile medical unit, realized that they were entitled for that service. So they resolved immediately in that meeting that they wanted the mobile medical unit to go past their village. They passed that resolution on to the doctor, who passed it on to the block official. And in 1 month, the mobile medical unit rolled into that village. And ever since then, twice a month, the people of that village were able to get the benefit of this service. In the district of Dharmapuri, there was another group of villagers discussing yet another checklist with a volunteer. This checklist was about the other services that contributed to health, like water, nutrition, and sanitation. One of the questions they were discussing was, do you know when the overhead tank that stores the drinking water in your village is cleaned? None of them knew it. And the next question was, as per the government protocol, are you aware that the date of the last time the tank was cleaned and the date the next time the tank is supposed to be cleaned, is it written on the overhead tank? It wasn't. They were quite agitated and they asked the local panchayat, the panchayat president, what is the process of cleaning the overhead tank? and they were met with a blank stare. They immediately resolved that one of that group would accompany the person who's supposed to clean that tank every time he goes there and helps them and monitor that the cleaning is done properly. The Panchayat president was quite taken up by this enthusiastic group and said that he would pay the daily wages to that worker only after someone from this group certifies that the job has been done. Now, these three inspirational stories of local change, what is the process that facilitated their emergence? That is the process that I will describe to you over the next few minutes. In the context of the National Rural Health Mission, which is the flagship program of the Ministry of Health, state governments all over India are encouraged to strengthen their health systems. And one of the core aspects of this strengthening is to get communities deeply involved in the process of health system strengthening and to increase the community ownership of this process. And each state government has the flexibility to do it. In Tamil Nadu, they invited NGOs, and my NGO was one amongst them, to sit down at the drawing table and come up with a process of involving communities. We started with a basic framework where there were two basic ideas. The first is that health is a fundamental human right. Health services are not charity or dole given by the government to some poor ignorant people. It's a fundamental right, and within that right is the right to participate in all decisions that contribute and that affect our health. The second point was that of systems thinking. Systems thinking is common in management science and economics and many other fields, and is making an entry into health systems research. Very simply, system thinking looks at the world as being tightly interlinked and adaptive. When I throw a ball at a wall, most times it's going to come back. But if I throw a ball at someone in the audience, the ball may come back, they may pocket it, or they may throw it on to someone else. It's unpredictable. It's innovative. It's creative. In communities, in health systems, we are not dealing with walls. We are dealing with people. And that is the core message of systems thinking. And these two fundamental ideas lead to a paradigm shift, where we stop seeing communities as passive beneficiaries, but as active innovators. We stop seeing the dichotomy between expert and layperson, and instead start recognizing that every single person is a partner in a process of change, each with their unique skill to contribute to this process. And we stop getting obsessed with an intervention and rather begin to engage with processes, however messy they are. And thus, when we sat down, we couldn't draw a linear log frame about what we're going to do. We came up with this squiggly diagram. In a sense, community action for health, the process that led to these innovative local stories of change, is about a gap between the desired status and the status that is absolutely there at the field. This gap in the current status and the desired status is measured by the users of this service. This information about the gap is then fed back to different levels in the system, and each level has its unique power to bring about corrective action. It is hoped that feeding this information up the system actually then leads to corrective action, which then leads to a reduction in the gap. Over the next few slides, I will dissect this concept diagram to explain to you who is this volunteer who was giving this questionnaire in the stories. The volunteer was part of the village committee. And who are these people? I will also answer the question, what is this process of checklists and questions and discussions? The process of monitoring. I will also discuss to you how that information is used at different levels in the system as the process of planning. And finally, the tough question. At the end of it all, do we just have innovative stories, or is there real change that can be measured? Each of these volunteers that I was talking about is a member of the Village Health and Sanitation Committee. These are people from the local village who have used the public health system. Thus, they have an intimate knowledge of how the local system works and of the local context. These members are trained by local NGOs who teach them about entitlements, about the rationale behind entitlements, and also about the concept of rights. The questionnaire is about converting individual experiences of the system into the information that can be transmitted up the system. In the questionnaire, each question can have 3 answers: green if it is good, red if it is not good, and yellow if it is patchy and irregular. Thus, the process converts individual experience into information, and many such individual experiences feed in to the village health report card, which is a representative of collective experience of the public health services in that village. Now, this village health report card forms the basis of the discussions that I described in the first 3 stories, where people from the village, NGOs, panchayat presidents and frontline health workers sit down to discuss the problem. A far cry from health planning, which was usually done by experts around tables in far off city capitals. We are moving from expert driven solutions to participatory solutions. With a simple planning mantra, how do we change what is red into green in 6 months together? This process of monitoring is done every 6 months to actually track whether services that were given a red color have now moved. And this information is then passed on to district and state officials to bring about change from different levels. And then the question, is this process just going to end up with stories, or is there hard evidence? And friends, I'm thrilled to share with you the next slide, which shows us the collection of results after 3 rounds of monitoring. And whether we ask questions of quality or availability, you will notice that in every set of graphs, the blue column here representing the first round, the red column representing the second round, the yellow column representing the third round, you will find that in every graph you will find that more and more people are answering the question with a green color, with affirmation, which shows that their perception of the health system and the services within the health system is actually improving. Whether we are asking the question about the availability of a particular service, whether we are asking the question about the educational component, is the person who is giving the service, the nurse in the village, is she explaining what is supposed to be happening, what's supposed to be done? The answers are yes. Is there an increase in the quality of services? And you will find in every round, more and more people are answering in the affirmative. And this is a graph about the midday meal scheme, which is in the news now because of the recent tragedy in Bihar. For over 2 years now, a number of village health and sanitation committee members have been monitoring the quantity, the quality, the taste, and the variety of diets. And you can see this was monitored for 2 rounds. You can see the improvements that were shown in every single round. Before I close, I would like to say that we are 13 years after the year 2000, when we were supposed to reach health for all. Today, we still have huge amounts of marginalization, vulnerability, and inequity, despite huge technological advances and huge amounts of investment in the health system. How are we going to overcome this? The first speaker of the morning and subsequent speakers have talked about co-creation. Unless communities are involved as core to processes of health system strengthening, unless communities are recognized as active innovators, as co-creators, as partners in the process of change, health for all will remain a distant dream. Is this some utopian, romantic idea of ours? No. I hope that my presentation over the last few minutes has convinced you all that involving communities and making them central to processes of change is possible here and now. Thank you very much.
Thank you, Dr. Rakhal. We have definitely seen a huge improvement from what you've done with the community to now. Just a few words of advice for the aspiring medical students. What would you say to them to take up a field like community medicine?
Well, I don't know if I can give advice, but I think what is most important, and I think which is a central message of every speaker that has come before me and that will come after me, who will come after me, is I think we need to follow our heart. It's the first thing. Second is, I think in the field of medicine, we tend to become extremely hierarchical and get so obsessed with the fact that we are experts and, studied 6.5 years and, studied for our post-graduation, that we forget to see the person, the human being who's sitting across our table. And I think that's like the biggest problem. When we stop seeing human beings, we stop seeing people with feelings, with suffering, and start seeing syndromes and, diagnosis. And whether it's, a neurosurgeon talking about, social, issues, whether it's a community person talking about service issues, I think that's the core, to recognize a human being.
Thank you so much.